Thank you for the nice introduction. You're pretty right. I grew up with shockwave treatments. I started first treatments about 18, 19 years ago. And I introduced this technology in our clinic. And I grew up with a very conservative orthopedic surgeon. And he told me, what kind of stuff you're introducing in my clinic? It's non-surgical. It's go away. Go to the physiotherapist. It's nonsense. But he was very related to the very, very famous urologist, Christian Chaussy, in Munich. And he was a very famous urologist surgeon. And when he first came to the conference saying that you must not remove the stones anymore with a knife, use just a non-invasive technology, they pushed him out because this is just money saving on the government side, but it costs your money as a surgeon, so they have no interest to follow the technology. But if you ask the patients, they have the options to have surgery or not surgery. It's pretty easy. 100% will say, I don't want to have any kind of surgery if I have the options to do it another way, even if the evidence is not perfect. If you look for the evidence for your surgical procedures, Nicola, the answer is, what kind of procedure is really evidence-based? Only very limited numbers of procedures that have in high evidence. So the German Orthopedic Society founded a group. It was the first group, the evidence-based medicine group in Germany 18, 17 years ago, because they want to know this technique is effective or not. That's when evidence-based technology starts in Germany. So numbers of publication comes out. Every year you can read about 200 to 300 papers published with many new indications, many new technologies, same debates. If you have focused with regard to energy level or indications or parameters to treat the patients. And at the end we have so-called standard indications. These indications were used for shockwave treatment since 15, 16 years. And they are accepted mostly by the authorities. And after a while, then they started with focused devices. The new other technologies comes out, radial, planar, combined technologies, and in new numbers and high numbers of publications comes out, and we have a strong scientific discussion, which is the best one. If you go for you cannot read it, but if you go for the website, it's called ismst.com. This is our international society. It's an open site. You can easily check parameters, devices. You can download some files and you can look for data. We have defined so-called standard indications. We have expert indication. We have very experimental indication. And some of the indications you've heard in the talk of Dr. Marlinghaus are related to expert indications or experimental indications. How does it work? At every conference, the same question arises: which is the principle, which is the working mechanism, which is proven to be shown that it's related to shockwave treatment? What we know finally that we are applying a kind of acoustic energy into the body, and the body reacts to these applied shock waves, pressure waves, sound waves, shock waves. This is called just physical definitions. The biological response is independent from the physical definitions, what we did many years ago. The body reacts. And we have the results from initial trials with Achilles, non-unions, shoulder pathologies, and we found that the working mechanism fits all other pathologies in the same way. So we have created huge numbers of new indications right now. And the question finally is a question from the authorities saying that you have no evidence. And the authorities say that we cannot recommend the coverage to pay for this treatment because there's no evidence in this kind of technology. Many years ago, these are the first publications coming out with outcome of calcific lesion of the shoulder, published in 1908. And you see the data publication from Markus Löw, Jan de Rompe, Matthias Buch, and myself. We found an efficiency rate about 70, 78, 67% without any knowledge how to perform a trial. Just we collect the patients, we do the treatment, and we collect our data, 50, 80, 200 patients, and there's no control group. We just look for the overall effect size. You can see, remember the effect size, 70%, 65% overall. For sure, that's not enough, and in these years when we founded the evidence-based group in Germany, and I was one of the founders of this group, the first trial, what we designed was a prospective randomized controlled trial to find out calcific lesion of the shoulder should be treated effectively with shockwave or not. What is the efficiency rate? And the design was with 3 groups in this trial. This is the keynote milestone in evidence-based medicine and shockwave treatment in orthopedic surgery as well. And the first group got high energetic shockwaves with 2 times 1,500 shots. You see the energy flux density 0.32 millijoule per square millimeters. This was defined by our experience based on the expert meeting. Application interval was 2 weeks, and we follow up the patients up to 1 year. No local anesthesia was used. The second group got the same amount of acoustic energy, but the application rate was different. 2 times 6,000 shots. You see a quite lower energy level down to 0.08 millijoule per square millimeters. Interval again 2 weeks, same follow-up periods, and same concomitant therapies options, and no local anesthetic was used. And the real placebo group was defined as getting nothing. They designed placebo setup. They have a polyethylene foil with air chambered ears inside, so the pressure wave or acoustic wave or shock wave cannot pass through. We did measurements behind. We found that no energy was directed forward, past the polyethylene foil. And the outcome was comparing the low energetic group versus the placebo group. You have a laser pointer or something? No. This is the placebo group up to 12 weeks after the treatment. And this is the low energetic group. You see that right at month 3 and 6, there is a statistically significant difference. At 1 year, there's no difference anymore. So the outcome looks pretty same after 1 year. But in the range in between, 3 months and 6 months, there's a better outcome in favor for the active group. That means low energetic extracorporeal shockwave therapy. The high energetic application means 2 times 1,500 shots, 0.32 millijoule per square millimeters, remains statistically significant in favor for the active group up to 1 year. We have not followed up the patient longer than 1 year, but in all these intervals, we are better. And right now, the final question is, what is the better option? The high energetic treatment modality or the low energetic? And you can see easily on this slide that the high energetic shockwave treatment is even better than the low energetic shockwave group. And I submitted the publication to the JAMA, the Journal of the American Medical Association. And the review process took me about 18 months. And I have hundreds of papers to be answered because they are very skeptical about this treatment. They read about shockwave treatment, they heard about the discussions, they want to have discussion in this high-ranked journal. It's very risky to accept this paper. And we did hours and months of statistical analysis, and finally they accepted the paper for publication. And a couple of days after I got the acceptance, I get a letter from the editorial board saying, we want to have 5 original paper sheets from patients, 5 original documentations out of the whole range of, they found the numbers, number 41, number 80, number 22, the original data. Not copies, original data with all signatures, everything on it. It was a multi-center trial. It was monitored, so we are happy we can collect these data. We sent it to the States. It took 1 week later, the paper come back without any comment. So they found that it is real patients in this group. So it was accepted and published in 2003. And from this point on, we have a very step forward with regard to evidence-based level if we talk about extracorporeal shockwave therapy. resorption of the calcific lesion for sure was one of the secondary endpoints. And you see also easily that the high energetic focused extracorporeal shockwave therapy is better than the low energetic shockwave group. And so we reach the highest level for all these options and modalities we have to treat calcific lesions of the shoulder. Even if this is the highest evidence we can apply, the authorities and assurances, they don't accept it. They're paying for medication, physiotherapy, acupuncture, surgery, for everything, but they don't want to pay for this. The reason for sure just financial aspects. It's not scientific reasons. They don't want to accept it. Still, we have this debate in Germany about accepted by the authorities or not. We will see what happens over years. Other studies comes out from SPEED, published in the JBGS, and they found that if it works on calcific lesions, it might work also for insertional pathologies of tendons. They're looking for shoulder impingement syndrome. Every orthopedic surgeon, every physiotherapist know that rotator cuff injuries summarized under impingement syndrome. It's a huge group of diseases, and if you use a focus device within focus about 5 or 6 millimeters in diameter, how and where to place the focus in the right spot. And not surprisingly, they fail to show it's efficient. So you see also, there's still a debate how to use it. And the question is right now is, can we improve it? Should we combine it with acupuncture? If you make this kind of acupuncture, it can work, probably. And what we did, this is recently newest data, what we have here is we try to improve the outcome, and we try to increase the biological response to extracorporeal shockwave therapy. We want to make something is called the biological enrichment of the tissue area. Focused extra shockwave treatment means you treat in very small spot. That means 1 centimeters, 1.5 centimeters in diameter. But pathology of a tendinopathy is much broader than just 1 centimeter. And I look for so-called pulse electromagnetic field therapy. The people know it as magnetic field therapy. It's about 20 years ago they came out with these devices. And same discussion as a shockwave treatment, there's no evidence to use it. But some publications found that we have an effect on these cell cultures with regard to all these inflammations. And they found that also specific inflammations like the interleukin system is effective positively to reduce the inflammation in inflamed area. So back to this publication, we look for a new device to use electromagnetic field therapy to improve the outcome. Electromagnetic field therapy can work because you have a lot of electric currencies along the cell walls, along the proteins, and everything which has an electric field has an electromagnetic field which can be influenced by strong electromagnetic fields. We found it by patients with an osteoarthritis of the knee came from the MRI, back from the MRI, and some patients reported that they have a pain relief after the diagnostic MRI. And they collected patients, and they found that electromagnetic fields have an effect on the pain situation in patients suffering from osteoarthritis of the knee. For sure, we cannot use an MRI to treat the patients. But the technology right now is used to produce smaller devices. They're able to improve the outcome by applying electromagnetic fields with up to 80 millitesla energy density, electromagnetic field energy. This is how it looked like. This is a device you can see on the right side when the energy is released, just magnetic energy is released. If your patient see how it works, you see this kind of injury is released to your hand, they immediately know that this is probably very powerful. If you let the patient feel the shock wave on your thumb, and you tell the patient that there's a lot of energy which is released, the patients believe in the technology. And what you have in the morning also is, if you talk to the patients in the right way, you stimulate the patient in the right way, you open the mind to the patient to be happy to get the treatment, to have positive thinkings. This has a strong effect also if you talk to the patients. So again, shockwave treatment, according to the guidelines or treatment parameters which we published in the JAMA. Focus device, we used the dual device from Storz, no local anesthetic was used. And the second group got shockwave treatment plus electromagnetic treatment, the EMWT. And the treatment was done within 4 weeks interval. And one group got shockwave treatment only, the second group got shockwave treatment plus electromagnetic field therapy. We have enrolled prospectively 86 patients. You see the treatment group and the control group. Mean average, the primary outcome parameter was defined as the change from the constant Merlin score and the change on the VAS scoring system. And then we carefully looked for the data. This is the constant Merlin score. These data just 3 months ago, we got these data. Outcome after 24 weeks, you can see that the concept Merlin score was improved, similar to the study we published in the JAMA. But if you combine this treatment with another soft tissue conditioning or enrichment technology, like magnetic field therapy, the outcome is even better. So in the combination, you have a better outcome clinically. Same was found if you look for the VAS scoring system. You see the decrease in size was very similar to the previously published studies in the JAMA and the JBGS for Markus Löw. But in the combination, you are better. This is our newest knowledge we have. It's a prospective controlled trial. And we are on the way right now to publish these data to make it visible for scientific communities. Radiotechnology, same indications, shoulder pathology, suffering from insertional tendinopathies. The outcome showed that you have an improvement, but there's no difference between the placebo group and the active group. So this study group failed in the same way as the SPE group to show there's a difference between the placebo group and the active group. Bad thing is that the authorities, they're looking for these publications saying that it's shown that it's not working, so why should we cover it? There's a new version available. Not now. Update? No update now. The update takes just 1 hour. Okay. I must find my slides right now. That's it. Okay. Next slide comes from the first Chinese group. The Chinese took many years to look for the technology. Because authorities, they cannot buy a machine to bring it into China. Right now they have the machines, and you will see in the future that many study groups have published their data in very ranked, high-ranked journals. This is one of the publications, they analyzing the effects of shockwave treatment on long biceps tendinitis. And was a prospective randomized controlled trial, and they have defined the change on the shoulders questionnaire score as a primary outcome, followed the patient up to 1 year, and they found with the radial application, 1,500 impulses, 8 hearts and 3 bars application pressure, that the radiotechnology is performing very good. And you can see that the VAS score in the placebo group just changed just slightly, from 6 down to 5.5 in the active group, from 5.6 down to 1.4. This is a strong decrease in pain. Surprisingly, and I'm working very much with randomized controlled trials, is that the improvement in the placebo group is just a very little bit. Maybe that the patient have an idea where they were allocated to. If the patient have an idea in which group they are randomly allocated to, you influence the outcome. plantar heel pain, this is a classic indications, and with these classic indications we have right now many publications. You asked about radial or focused. Because it's easier to apply the radial technology, more publication will come out with the radial technology. But also the radial technology have found to be effective to treat these insertional pathologies as well as the non-insertional tendinopathies. I published one of the radial studies in the American Journal of Sports Medicine together with very famous foot surgeon, Lowell Weil, Keith Feder, John Seenstra, Barry Skirren. So huge people were involved in this trial, multi-center trial, internationally done. And you see the outcome is good in the active group, but you see also improvement of 44% success rate in the placebo group. And these patients, they did get nothing, just really placebo. We published recently the FDA trial supported by STORZ. It was a trial which took about 10 years, 9 years. Mr. Marling has known how many years we did investment, and it cost around about 1 million euro, something like this. So it's a huge investment for a company just to show we have an evidence to use the device, to show that we have evidence to use this technology. And the JBJS accepted it last year for publication with Hans Gollwitzer as the author. The treatment parameters accepted by the FDA, which is right now best evidence, what we can recommend is if you use a focus device, 0.25 millijoule per square millimeters, 3 treatments with 2 weeks apart. So we have a 2 weeks of treatment interval, and no local anesthetics should be used in all these patients. And you can see it in contrast to the anecdotal studies we did. Right now we have very strict and rigid inclusion and exclusion criteria. And we have, in this trial, we have 2 monitors. They're traveling around, checking every paper sheet, every signature, every parameter. So there's a very, very high work we have to do. Okay, and you see the patient have to perform many of these so-called non-surgical options, insert modifications, NSAIDs, local injection of cortisone, and the first time that the FDA asked us to follow a washout phase. So if the patient had gotten local injection, for example, with cortisone, they have to wait at least 6 weeks before they were enrolled in the trial to be sure that really we have no effects from previously done studies. And the outcome showed that the percent change in comparison to baseline shown that we have about 70% of the patients showing excellent outcome in comparison to about 34% of the patient after getting placebo. This is real strong placebo. The patient have no idea. And we asked the patient afterwards, they have any idea which group they were randomly assigned to. They have no idea. So the blinding mechanism works in this trial. You see, not surprisingly, the outcome is pretty good if you use the shockwave device. And also not surprisingly, the success rate has the same high as previously published data 20 years old. So the outcome is quite the same. Our knowledge about placebo and study design is improved dramatically, but the key message is still the same. For sure, we have less doubt right now, as you can discuss it more strong, more scientifically. But again, if you look for the side effects, for example, and there's no device-related side effects. The patients sometimes report about pain during treatment. Patients getting placebo treatment reporting about swelling and numbness after treatment, which lasts up to 4 or 6 weeks. So this is very strong to ask, how can you influence the patient? If the patient have an idea to get real shockwave treatment, they come in an office with a printed PDF file saying, in the website showing that these kind of side effects can occur, numbness, pain during treatment, and they expected the pain, and they report to the observer that they have pain during treatment. They have still numbness, they have still swellings. So for me, from scientific point of view, it's very interesting to see how we can influence the patients. And during this phase, when we have hundreds of patients, they want to be signed in to be enrolled to the trial. We did a trial in Munich to compare placebo versus placebo. Because I want to know how can I influence the patients. We have two groups in our office. One group, two groups they all got placebo treatment. One group was told they get shockwave treatment, but they get placebo. One group was told that they get placebo, and they get placebo. And the patient get a fake telephone call about randomization, saying that the patient is randomized to the shockwave group. Okay, thank you, hang up. Until the patient, right now you get shockwave treatment. And the patient is happy, shockwave treatment. The other patient here listening to the same phone call saying patient is randomly assigned to get placebo treatment. And the patient say, I get placebo treatment, why should I wait? I can go. Now you get placebo treatment, we will see. And the difference in outcome is more than 25%. 5%, 25% difference in outcome up to 12 weeks, just influencing the patient. There's nothing different in between the group, just the communication to the patient. So this has to be discussed very strong in scientific work. Seriously, back to the FDA trial, the FDA asked for sure for the evidence of side effects with regard to real significant lesions like tendon ruptures, nerve injuries, but nothing occurred. After this trial, there are many publications right now available in the scientific world. You can download all these files and see that it's confirmed by many scientific groups right now that shockwave treatment is very effective. Same discussion with the non-units, bone pathology. And there's many technologies using nails, screws, plates, every kind of bone graftings. And if you ask for the evidence, why you use either Crest bone graft? There's no evidence. This was just anecdotal recommendations by the very old orthopedic teachers. They do it. But the two publications right now were coming out by John Ferrier and Caccio. They published the effect of shockwave treatment on non-unions on the fifth metatarsal Jones fracture. And they have divided, like the study from John Ferrier. He has three study groups. He has one study group getting shockwave treatment with a specific machine, a Dorney EPIS machine. Second group get shockwave treatment with another machine from the Storz Mundlit device. And the third group gets surgery. The full cycle of surgery. It means removal of the implants, decortications, debridement, lavage, new osteosynthesis, spongiosoplasty, reosteosynthesis. Everything was done. This is a strong invasive treatment. And as you can see on the slides, up to 2 years, there's no difference in between the groups. There's no difference. If you apply shockwave treatment or you perform the full cycle of the heavy surgery with all these side effects, infections, non-unions, everything, no difference in outcome. The healing rate is up to 94%, 92%, or 95% in all these groups. So right now you should recommend shockwave treatment because it's much more less invasive with the same efficiency rate. What else is needed? So how can we improve our scientific knowledge? Now we cannot make it. We have reached the summit of scientific work in shockwave treatment. As far as I know, there's no technology in orthopedic fields with so much excellent trials showing the efficiency of any kind of technology, and it's still not accepted by the authorities. This, for me, is very surprisingly. And I discussed it with the authorities in Germany. I've submitted every publication saying much more better than every surgery, every needling, every medication, every physiotherapy, every insert. It's accepted. Please accept the technology. And the answer is you have the highest evidence, but we have no idea it's useful or not. So this is a stupid answer. So I cannot deal with this answer, but the patient can make it. The patient finally, if the technology would be bad, with worse outcome, the technology will not survive because the patient will move away. If you performing shockwave treatment in a huge number of patients and this is nonsense, it's not working, it just costs money wasting for the patients, the patient will not come back to your office. If you do it back, if you do it a good way and you're very effective, then the patient will recommend you as a good surgeon. So the patient make their own evidence by the feet. So easy take-home message is, right now, is we have excellent technologies, we have many devices, we have good data. Don't wait for the acceptance by someone. Apply and offer the technology to the patient, because then you treat the patient in the best way available right now. Thanks a lot, and I'm happy to be here.